find out more, I ended up Googling your profile and reading about half your papers last night.
Wow.
I'm very honoured.
Yeah.
Well, I was just going to say, I'm going to have a look as well, because there seems to be some overlaps in interest. But let's make a start, and then we can talk about that more, about Rosie's papers in the discussion part.
Sounds good.
So welcome, everybody, and thank you very much for joining us this morning, this evening, wherever you are in the world, for today's Open Digital Health discussion. My apologies again that we had to reschedule it. I know it was supposed to take place later on in the day, but there was a bit of miscommunication. We messed up basically, and Rosie reminded us that she had chosen a different slot, so we had to change it last minute. So thanks that you could still make it. Yeah, so today it's my pleasure to introduce Dr. Rosie Dobson. And Rosie is a psychologist and researcher at the University of Auckland in New Zealand. So she's joining us now late in her evening. So thank you, Rosie, for that. Her research work involves the development and evaluation of mHealth tools to provide accessible support to people in their daily lives. She has been involved in the development and trial of mHealth tools in a range of areas, including diabetes management support, maternal and child health, alcohol brief interventions, behavior, lifestyle behavior change, and pulmonary rehabilitation. She has been an invited expert on the WHO's Be Healthy, Be Mobile global mHealth initiative for non-communicable diseases. So really interesting profile here, and I'm very excited to hear Rosie's talk today. So that will be what starts us off, and then we will follow up with some questions and discussion. So over to you, Rosie.
Thank you very much for that introduction. So thank you for joining us. It is 10 o'clock at night here in New Zealand, but I'm imagining most people are calling in from other parts of the world. But I'm going to talk to you today about one of our programs called txtpēpi, or txtpēpi. And this is a maternal health program for māmā and whānau, so mothers and families, that was rolled out or developed and rolled out in an area of New Zealand in 2021. This is very similar to a number of other programs that we've developed over the years, where we've had to, and we've looked at how we adapt a program for another population. And we've done that here in New Zealand, but also in the Pacific Islands as well. So we've worked closely with island nations near New Zealand, where we can take the programs that we might have here and support them to roll them out in their communities as well. But often there's a huge amount of work that goes into adapting them, and that's kind of what I wanted to talk about today. So to give you a bit of a background, in New Zealand, in the Auckland region, for those that know New Zealand, it's the biggest kind of population of New Zealand is in the Auckland area. We've had a program called Text Match, which is a text messaging maternal health program running for about sort of 7 or 8 years now. And this is a program that is delivering free education and support to both mothers during pregnancy and the postnatal period, and then also their family members, so say fathers, but also grandparents or aunties or uncles, anyone who might be involved in supporting that baby. And the program is designed to support them, particularly around things like healthy eating and exercise and movement, but also more broadly or more holistically around lots of other aspects of good health during the pregnancy and postnatal period. That program, we developed it specifically for a number of populations, key population groups where we see inequities in health outcomes. So we see those in our new migrant communities, so our particularly Asian and South Asian communities in the region, but also our Indigenous population, the Māori population, and Pacific Island populations. And so this program was specifically designed for them, and had an extensive development process that involved a lot of engagement of the end users. But I'm not going to go into that here, but you can see that, and I can direct you to our paper where we've published that process, or I'm happy to answer questions about that after this. But just to give you a bit of an idea, it's a completely tailored and personalised program. It's completely free to end users, and it's hugely accessible because it's just text messaging. There's no apps or internet involved in this, which makes it much more accessible to those that might be experiencing hardships in accessing existing services. The program, as you can see there, is tailored based on their language, but also their culture. So there's different messages. It includes different examples of services or food types based on the culture that they identify with. And there's also different messages based on whether they're, say, the mother or a whānau member or family member. And the messages are timed based on where that person is in their pregnancy or in the postnatal period. So there's 16 different versions, as I mentioned, of that program, and the message library has over 6,000 messages in it. So you can imagine it was an extensive development process to get to that program. Where that orange circle is where the Auckland region is in New Zealand. And although this program had been running for a number of years in that region, it had never been delivered anywhere else. And we had some colleagues in what we call the Lakes District in New Zealand, which is that green area, which includes places like Rotorua. For those that may have travelled to New Zealand, it's a very frequent tourist destination, but it's an area where it's a much smaller population and a diverse population in terms of there's a lot more people living rurally and small towns where they don't have access to some of the services you might get in, say, a big city like Auckland. And what we see is much poorer health outcomes in those populations. So rates of immunisation are lower, childhood immunisation, and other metrics that we typically use to measure health outcomes in our child populations. And that region has lower proportion of, say, new migrant communities like South Asian and Asian, but it has a very high proportion of Māori, so our Indigenous population. So we had colleagues that were based down there who were really keen to see a program like the Text Match program come to their region, and were really keen. They didn't have the resources to develop things like this from scratch, but it also seemed pointless to developing something from scratch when we already had a program running in Auckland. The issue was it's not as simple as just taking this Auckland program and taking it down to the Lakes region. So years of experience in terms of developing and implementing mobile hub programs, including text messaging programs here in New Zealand and in the Pacific Islands, has taught us that even within quite a close geographical area, it's only about 3 hours to drive from Auckland to the main city in the Lakes region. There still needed to be a work with the local communities to get local buy-in for a program. And without that local buy-in and without adapting it, we wouldn't see that program be successful long term. So we obtained some funding to adapt the Text Match program and deliver it in this Lakes District. So we would funded to roll out the program across the district and evaluate the reach, adoption and effectiveness of it. So the process we went through to adapt the Text Match program was actually quite extensive. So we formed what we call a local rupukaitiaki. So what that is it's a governance group. That's the Te Reo Māori language there, and there'll be a few terms that I use that are that language, but it's basically a governance group that pulls together key leaders and experts within the community. So we had representation from service providers as well as members of the health service, the government funded health services there, and community organisations, and they all came together to provide governance and advice over the program and be involved in the key decision making. We also engaged with what we call local kaumātua, so local leaders in the community, so well-respected leaders, cultural leaders. So we needed to ensure that they were on board with a program like this and going to support it, because without their support, we knew it wouldn't be able to be, it wouldn't be taken up by the communities. We then had meetings and focus group with our local end users, so women and their families who lived in that region. So we'd done extensive engagement with end users in the development of TxMatch in the Auckland region, but we knew we had to connect with the community again down in this region. And so we conducted further engagement with these families. We then rebanded the program. So what we know from years of experience in this space is that the branding of the program is really, really important, and the branding needs to come locally. So local, that was the name that was gifted to the program, txtpēpi or txtpēpi, and it was a name that the community there could own rather than an Auckland name, which was seen as being something from outside of their region. So we took all the feedback from that governance group and our engagement with the other groups to adapt the messages. And there wasn't a huge number of changes that went into the program, but we pulled in the Māori version of the TxMatch program and we tweaked the messages to align with the local services that were available. So a lot of the time it meant changing the contact information for services that are available to people, but it also involved putting greater emphasis on some topics that were particularly relevant to that community. And this was a community that experiences higher deprivation and poorer access to services. And as I mentioned before, it's also a population where there's a higher rural there's more people living more rurally, and so we needed to be ensure that we were directing people to accessible services, that they weren't services that were 3 hours away if they needed to attend in person. It was the closest possible service to where they lived. So we needed to add an additional tailoring based on their geographical location. All our messages undertook expert review, and that had happened in the initial phases, but we knew we had to do that again because we had adapted them. And then we had them retranslated into Te Reo Māori by a local translator to ensure that the dialect was correct for the local population. And then again, having that back translated and reviewed before we rolled out the program. Just to give you a bit of a summary of how this program is tailored. So people can enter the program either during pregnancy or in the postnatal period, and they can be a mother or be a family member. And then based on their language preference, so whether they want English or Te Reo Māori, whether they're a mother or a whānau or family member, where they live in the region, their messages are tailored for them. We also insert the person's name into the messages, so they're obviously personalised to them. And then if they're receiving the messages in pregnancy, the messages are tailored based on what their due date is. And then if they're receiving the messages in the postnatal period, it depends on the age of the baby. And then we also insert the baby's name into the messages, and we also include the correct pronoun based on the baby's sex at birth. And people can receive the program for as long as they want during pregnancy and through the postnatal period up until their child is 2 years of age. So as I said, there's the 2 different languages, which means there's 4 different versions of the program, depending on whether they're mothers or family members. And as I said, we tailor and personalise the messages as well. So the program is completely free to receive. So people can sign up to it, as I said, at any stage themselves, or their healthcare provider can sign them up for it if that is more accessible. And then as soon as they sign up, their messages start. And then at any point, they can free text the word stop if they'd like to cease the messages, and their messages end straight away. And then at points during the program, we ask them for feedback, and they can free reply with their feedback. So we are able to 0 rate their reply messages to ensure that there's no cost whatsoever for someone to engage in this program. And then if they receive the program during pregnancy, once they get to the around 40 weeks, which is when a baby's due, they can free text the word baby to switch them over to the baby messages. So we don't automatically deliver the baby messages because we wouldn't know the age of the baby. delivery, or when the baby's date of birth is, they do have to engage to switch over. And they've got as long as they want to do that. They don't have to do it the day the baby's born. So we, as I said, we rolled out this program. Now, in an ideal world, we would want to look at whether this program was effective and run sort of a randomized controlled trial or some type of trial design where we can look at the effectiveness. But what was really important to us is that this is a program that had no barriers to our communities receiving. So this is a low-risk intervention, a low-risk mHealth intervention. We know from evidence across the world that text messaging interventions are low risk, and we know that information and support messages like this that are just delivering standard care information in a different modality are also low risk. So there was no reason to create barriers to people receiving this or only delivering it within a research setting. So what we decided to do is, as an implementation study where we rolled out the program, and we didn't sign people up for research at the point of enrolling with the program. So anyone could sign up for it, and we didn't want to prevent people from signing up by adding a research element to the program, and anyone could sign up. We also didn't want to sort of randomize anyone to control groups or waitlist controls. So what we instead did was looked at a mixed method evaluation where we conducted the research after people were in the program, and we had different elements to this evaluation. So this is our program logic, but just to give you a bit of an idea that we were able to look at some of those key impacts that we would expect of people receiving this program, like seeing increased engagement with immunisations at key points, so childhood immunisations, increased engagement with health services. So there's key kind of milestones that we would expect, and the messages align with those. So there are messages reminding people to engage with these things, as well as key behaviours like healthy eating. So what we were able to do is choose some of those and decide to look at those in terms of outcomes and changes in those over time. And then also we were interested in our end user feedback of the program, so the usability and acceptability of the program, and also our stakeholder feedback. So those people in the community that are working with these families, interested in their feedback on the program, particularly the usability of it, but also thinking about the sustainability and going forward with a program like this. So to give you a bit of an idea, this is a small region, probably compared to some of the big cities around the world that you might all live in. But in the first 12 months that this program was live, we had 278 people register for the program. We were really pleased to see that the majority of these people were Māori, were our Indigenous population, because this is who this program was designed for. The vast majority of the people receiving the program were signing up as mothers rather than family members. So it's only a small proportion that were the family members. And what we saw was the vast majority were also signing up for the English version of the messages, which would be expected because that is the most common language here in Aotearoa, New Zealand. During that period, the program sent over 32,000 text messages to those people. So roughly people who receive the program get about 3 messages per week, but that does vary slightly. So there's slightly less messages towards the end of the program, for example. And so in terms of our inclusion criteria for the evaluation, what we decided was that when someone turned 6 months old, they were invited to take part in the research. So we had a local coordinator call these people and text them to ask them to take part in the research study. They did need to meet some criteria of being registered for the program during pregnancy or before their child was 6 weeks of age, and they needed to be a resident of the region and be able to provide informed consent. And so 133 people met our inclusion criteria, and 51% of those consented to participate. Of those that were eligible, our eligible population, the vast majority, well, the majority were still active in the program at the time that they were eligible. So they didn't have to be active to be eligible. We still want to include people who have withdrawn or quit the program. But interestingly, the majority were still active. And of those that had quit the program, The 21 had tech stop, which is where they have actually made an active decision to cease the program. And then 15% had just not switched from pregnancy to baby. So they hadn't gone through that active process or of engaging with the program to switch them over from pregnancy to the postnatal messages. The mean duration of messages at the time of follow-up was 7 months, but that ranged from someone who'd received less than a month's messages through to someone or a number of people that have received 14 months of messages, so over a year of messages. And a lot of those people are still in the program today. So what did people say about it? Well, we interviewed 40 end users, and these included people who had quit the program. And as you can see, everyone thought that the messages were useful and that they were relevant to them. And I think that is a credit to the fact that these messages, all the engagement that went into designing this program. And so that consultation with end users to ensure that we were delivering the right type of messages for their context, but also for what they wanted. The vast majority also reported the messages to be culturally appropriate and easy to understand. What is, I suppose, a really important metric here is that 98% of people said that they would recommend the program to other people in their situation. In terms of what they perceived the impacts of the program to be, as you can see here, that a key factor in this was feeling more supported. And this is something we consistently see across text messaging based programs, that they are really powerful in making people feel more supported because they arrive in those moments where people can feel quite isolated or disconnected from health services. But as you can also see, the vast majority also reported improvements in their knowledge and understanding. We also interviewed some key stakeholders. So stakeholders here were health service providers in the community and across the region. And they saw strengths of this program being the family approach, the fact that there were very few barriers to the types of people that could sign up for it. So we weren't just delivering a program to mothers. A lot of health services, both here in New Zealand and internationally, are targeted towards the key patient or the key person with the condition. They often don't involve everyone else in the family. And if they do, they often only involve the immediate family. This program could allow anyone who considered themselves part of their family. And that was seen as a big a strength of this program. And key stakeholders also reported that the empowerment that their program provided and the reminders and prompts to engage in things like immunisations were key strengths. They also talked a lot about the fact it was text messaging meant that they were able to get people onto this program that they weren't able to get to engage in other services like in-person services, where there were just too many barriers for them to engage with, such as travel or logistics, but also just where there were maybe people who don't want to engage with our traditional health services. Text messaging was much more accessible and they were more receptive to it. There were a number of suggestions for improvement, though, from this stage of these interviews, and one was the fact that these programs need to be constantly adaptable. So even though we'd recently adapted it for this region, particularly in the COVID context, it was highlighted that there's always kind of key issues for a population, and it would be wonderful if these programs can be very easily accommodating of these key issues. So right now in the region that this program runs, there is a big push for measles immunisation. So there's been an increase in measles, and so they're trying to encourage measles immunisation. And they said, it'd be great to add some extra messages in around that because that is a topical issue for us right now. They were also keen to see all the different languages come down to the region, even though they had smaller proportions of people speaking languages like Korean or Japanese. But they also wanted to see greater marketing and communication around the program, and particularly the communication with the stakeholders. And another thing was, even though we made the sign-up process for this as simple as possible, it was just an online form that anyone could fill out on their behalf, they still wanted to see that simplified. So one of the things we did do is look at alternative models or methods of enrolment. And so one of the things we did, because we'd had this engagement with our local communities, was a key provider of antenatal services, so services during pregnancy, a community organisation that was delivering things like antenatal education. They were signing up people for, or women in whānau for lots of different services. So they discussed with us the option of creating one enrolment form for all their services and allowing an opt-out option for all the different services. And so we added txtpēpi to that. And so suddenly they were signing up for all different services. And if they didn't want the txtpēpi, they could tick the box and not receive that. And so this was just simplifying it. So they weren't signing up for lots of different services, which took time and effort. And what we saw was a significant increase in enrolments when we did that, when we compared the pre and post. And we saw no change in withdrawals from the program, which was a key factor. We thought that, you know, people that were concerned about an opt-out option thought that we'd see lots of people signing up who didn't want to be signed up. And so they would quit the program straight away, but we didn't see that. So the key learnings from this is that end users need to be involved from the start. So, you know, even though we were taking a program from one part of New Zealand to the other, we still needed to engage with our target population to make sure that the program fit within the reality of their daily lives and their context. We also needed to engage and bring on health service providers from the start as well to ensure that they have ongoing ownership and support of the program. And it's seen as a local program, not a program that's from out of their region. And we also need to involve the health system funders and partners right from the start to ensure sustainability of programs like this. What is key is promotion and local champions. So that local buy-in is fundamental to the success and the sustainability of these programs. We need to make our content more flexible, and that is something that is a challenge in digital health and mobile health programs. Is often the content development starts at the, it happens at the start, and then there's not often funding to allow for content to be adapted over time or change based on different situations. And we need to do everything we can to minimise all possible barriers to signing up and using these programs, because the biggest potential for mHealth is to reach our populations that existing services are not reaching. So that's kind of some key points, but I'm happy to take questions and have a bit of a discussion around the program. So thank you.
Brilliant. Thank you very much, Rosie. Very, very interesting work, really fascinating, and great to see all the work that has gone into involving the stakeholders in such an extensive way and developing something that's actually useful for people, as we can see from the evaluation, which that's very impressive to see, like 98 to 100%, everybody seems quite happy with it. So yeah, amazing work. We're really happy to take any questions now.
Thanks, Rosie. That was really, really interesting. Really, it's we did a oh, can I ask a question? Sorry,
of course. Yeah, Ben,
butted in.
Yeah,
Sorry.
no we're just few people here.
I wanted to ask, so it made me think a lot. So we did this COVID intervention called Germ Defense, where we did a lot of very similar things in terms of basically focusing massively on implementation and rollout, and kind of being like, wow, we've probably got enough evidence that this is probably going to work, and it's definitely not going to do any harm. So how can we extend the reach as much as possible? Ours was digital rather than text messaging, which I guess kind of caters to a different population, doesn't it? But I wondered whether you thought there are any differences between like digital and mobile things in terms of implementation, whether there are specific challenges to text messaging ones that aren't for digital, or whether you can kind of think about them broadly as the same thing, which is just technological.
Yeah, thank you. That's a really good question, because they are obviously different technologies, but I think the key difference is just, as you highlighted, who the target audience is. And so the user populations, you're often designing for a different user population. And if we think about the success of those kind of programs, it's ensuring that they're accessible to that population and sort of easy to use. One of the biggest battles we've found with, being someone that has spend a lot of energy in the text messaging space, is it's very hard to promote text messaging programs. They're quite hard to market to people, whereas I do find it much easier to market a digital program, or whether it be a website or a chatbot or an app. People understand that a lot more easily than they do a text messaging program. It's really hard for people to kind of get their head around what a text messaging program is like to receive, and until they receive it. And so, you know, often people are like, oh, there's no way that can kind of have an effect. That's just really, you know, basic messaging. But the power of text messaging isn't often in the content, it's often in the way it's delivered. So it's the fact that messaging is a prompt. So every time your phone beeps, everyone checks their phone when it's a message. So, you know, that in itself elicits behavior change. Prompts are one of the key things we need in terms of, you know, developing or changing our behavior. But then the other thing that messaging does is it capitalizes on support. So, you know, the fact is that text messaging and phone calls were designed to connect people. And so just the fact we're using that modality again capitalizes on the fact that there's supportive mechanisms. So we know it works, but people find it really hard to kind of get their head around how a generic or a automated text messaging program could get them to feel more supported or to engage in behaviors or educate them. Whereas I think with a lot of our other digital tools, it just makes a lot more sense to people. So they are quite kind of easier to convince people or get them on board with it.
I can see one of the, because we found, I mean, our experience was actually we had this intervention that we knew worked, but to actually implement it long term, you kind of needed to stumble across a champion embedded, and that was basically just luck if that worked. And to be honest, it didn't in the end. But our experience was actually, I can completely see how getting a champion to support a text messaging service would actually be harder if they didn't know about it, because people were like, oh yeah, an app, that's definitely going to work. And like,
yeah, the champions are fundamental, and they're fundamental across whatever tools you're designing in the digital space. So whether that be a website, an app, whatever, you know, a new system for a clinician, having those champions who are your target end users is really, really important. So we often try to get champions in a few different places. So in this case, champions would be mothers themselves and whānau members in the community, but also maybe champions within some of our service providers as well. So, you know, champions work at engaging the target population, but they also work by getting on board the other key stakeholders that need to promote the program or support the program in other ways. But they're absolutely fundamental to the success of these programs. And it's a huge amount of work that goes into getting them on board right from the start. And I think that is what we, you know, invested a lot of time in with txtpēpi, and it felt like a really kind of slow process. But we needed to get those different people on board with the program, otherwise we wouldn't get, you know, any kind of buy-in in the community.
That's me. Can I ask one more? Well,
yeah, go ahead.
So like a really good friend and colleague of mine did a intervention that was a text-based messaging intervention for, it was actually smoking cessation for pregnant mothers, and she found, I'm just kind of interested in the psychology of it, because what she found was that people really viewed the messages, which they knew were automated, as a person, and they were replying to them and having discussions. And I wondered whether you did any, because I know the talk was kind of focused on this implementation development side, but I wonder whether you really delved into the kind of identity issues and what people were thinking and things like that.
Yeah, so we've talked about this at length in other places, but you're absolutely right. People build a relationship with an automated system with messaging, and I have so much evidence of that just by scouring our incoming message logs. Like this time of year, we will get everyone saying Merry Christmas, you know, and we get a lot of God blesses, we get a lot of, you know, a lot of thank yous, and people talk to us like there's someone checking those messages, even though when we interview them, they say, oh, I know it's automated, I know there's not someone at the end of it, but it feels like there's someone. We ran a diabetes self-management program via text message that was in a randomized control trial, and it was a program where they were signed up to the program or referred to the program by a clinician. So it was either, say, a nurse nurse or a doctor or a dietitian, someone that was providing diabetes care. And what we found was that people thought that it was that person that was behind the messages. So we'd get a lot of incoming messages saying thank you, and then that doctor's name or the nurse's name. And at first I was always like, who is this person? And then I'd look back and see that they were referred by that person, and they believed it was that person. So what we're actually seeing, we've got interview data to support this, is that it actually is enhancing that clinician-patient relationship, because they feel like their clinician is connecting with them outside the clinic environment. And the diabetes case study was a really good example of that, where this was for people with poorly controlled diabetes, but who were often still only seeing a clinician for 15 minutes every 3 months. And so they're managing that clinician 24/7, but they're not feeling like they're getting that clinician support very often. And suddenly we were messaging them every day, and they said it felt like that clinician cared about them in their everyday lives. And that has knock-on effects in terms of behavior change, because suddenly there's accountability, there's that sense of someone maybe checking in on them and feeling like someone is actually going to notice their hard work or the behaviors that they're engaging with. With this maternal health program, we often see the same thing in terms of if someone has been referred to the program by a community service or by a clinician, they will message back with that person's name or engage with that person. But for people who sign up, they still do engage with those thank yous, with the yes, I knew that, or I didn't know that, or often they'll try and have conversations with us, even though they'll get an automated response saying that this is not if they've got questions, they need to contact another service, and we provide that service for them. But there's thousands of messages in the message log of thank yous, happy Easter, Merry Christmas, Happy New Year type things.
It's really interesting. Thank you.
And I think it does provide that, the evidence that, because often people are a little bit hesitant with mHealth, that they always see it as being, we should be aiming for in-person care. And I don't think anyone would argue that an in-person care model is the optimum model for, supporting people. But it's just not feasible. And Tex mentioned txtpēpi are examples of where these programs they came out of an issue where we were seeing poorer health outcomes, and our services were not meeting the needs of communities. And that's not okay. And so we needed to look at alternative ways of engaging with these communities. And what we were showed is we could connect with these communities with something as simple as text messaging. And there, again, I haven't presented everything here, but with the txtpēpi program, we have actually asked them as well whether, because of the messages, they engaged with other services, and we have some data to support that they are actually contacting some of the services that we link to in those messages. And women say that they felt more empowered to do that because they felt like they had this relationship with txtpēpi or text match and trust in that program. It gave them the confidence to then engage with other services because we were recommending those services.
And one of the nice things, I guess, is because we've struggled in that referral, that initial referral, sometimes that is really challenging when healthcare professionals feel like it is a burden. And you were saying they feel like they're doing nothing at all. But I guess the nice thing about this is because it is about you're almost, one of your key aims is to establish that relationship and strengthen the use of other services. It's so quick to refer people and sign up to them. And it's so low risk that it's not like signing them up to a complex behavior change app where you need to kind of explain how to do it. And it's really nice. It's sort of a gateway intervention in a way.
Yeah. Well, you're exactly right, because one of the biggest issues with app-based interventions is actually getting people to engage with it, because they often need some support to, often it's even just downloading or signing in, or there's always an extra barrier or a step that makes it more complex to engage with. And what we actually found was that even clinicians referring someone is a barrier. So clinicians, I'm sure it's the same around the world, is that they're so stretched for time. We've got massive workforce shortages that, actually there isn't enough time to add on all these other things in a consultation. And so, that's where that opt-out enrollment option is actually really, I would encourage people to consider when thinking about the best way to get people onto these programs. And we've received no negative feedback around that. And as I said, no change in our dropout rates from the program. And we do analyze the opt-out numbers. So exercise autonomy and do opt out, and that is important. We wouldn't want to see no one doing that, but we do need to look at alternative ways to get people onto these programs to ensure where there's no barriers whatsoever. One of our programs, our pulmonary rehabilitation program, that is an app-based, is a text messaging app and wearable sensor. But what we do is we allow people choice of the modality of the intervention, because what we found was that if you expected everyone to engage with an app, there were straight away you got people disengaging, because not everyone A can engage with an app, or B wants to engage in an app. And so there are a certain proportion who only get text messaging with that program, and there's others that engage with all the other components as well. And so I think in an ideal world we have choice, but funding limits us there.
Yeah, it's really great. Thank you.
Thank you.
Very, very interesting. Thanks, Ben. And this is really what we're trying to do here, having some interesting discussions. I'm just having a quick look here. So Elisa says, I also want to say thank you for the great presentation of your work. This is so important in supporting new mothers. So
thank you.
That's great to hear, Elisa. If you have any questions or wanted to say anything, also please feel free.
Thanks, Ben. Yeah, I'm welcome. People are welcome to contact me outside of this as well. But Elisa, I think you've got a really important point there around in supporting new mothers as well. This can be a period of time where people are very, very isolated, and COVID was a particularly hard period for new mothers, having to cope with things within the home with very little support and in-person services. So being able to run a service like this where people felt supported in those moments where they were very alone was really, really powerful. And we got some really positive feedback around that. And yeah, so I think, in the context that we've been through over the last few years, having options like this that provide an alternative mode of reaching people is quite powerful, whether that be in the maternal and child health space or in other areas as well. So if we look at particularly elderly, where there's, often people don't develop digital interventions, we actually find that elderly were even more isolated during COVID, and there was more risk for them to be engaging with health services, and so even more power in terms of looking at alternative modalities for delivery.
Okay, Lisa's saying here, she also became a mother during COVID era, so can very much probably feel for that.
I'm sure you can that resonates with you. And I think I between developing TxMatch and txtpēpi, I became a mother as well, and it wasn't until I received the messages in the right stage of my life that I realized how powerful they were as well. And I think that comes back to that comment around how challenging it can be to market and communicate these programs with people who aren't in that context or haven't received a text messaging program before. And I think that's probably similar across other digital modalities as well. It's not until people really give it a go and actually get engaged with it, they really understand how powerful these programs can be.
I would also imagine that part of why people feel or build this relationship with it is because of all the great work that you've done in terms of adapting the messages to the local dialects, languages, and with messages that they're perhaps also already familiar with. That is probably also something unusual, right? I mean, I don't know about New Zealand. I'm sure there's a lot of great work around, kind of adapting to indigenous sort of populations, but I'm still sure that they appreciate that this work has gone into it.
Yes, yeah, I think you're absolutely right. We use the language and the terms and examples that are local to them. So, and it comes back to things like, where they live, referencing a service that is down the road from them versus one that is an hour's drive away makes it that much more personal to them, but also the language we use. And so when we were developing TxMatch initially, we initially thought we'd just be able to create one version of messages and then translate that into the other languages. But in that initial end user engagement, it was really, really clear to us that the cultural practices and the nuances between cultures were so different it, that we needed to create 4 cultural versions of the program and then translate the program. So the messages for a South Asian woman actually look quite different to the messages to an Asian woman or a Māori or Pacific woman. And that is because there's different health issues and different priorities in those populations, but there's also different practices. They eat different foods or prefer different foods. And so we're actually putting more emphasis on the things that matter to those communities. And so, and then what's important with that is that we don't assume that one version is right for a person based on their demographic information. We always give them autonomy or choice over the program they receive. So if someone was to sign up and their ethnicity was, say, a Japanese, we wouldn't automatically give them the Japanese version of the program. We would get them to self-select the version that they would like. And we see that a lot with younger families, particularly where we have a lot of cultures, mixed cultural families. And so it may be that you do have members of more than one cultural group within a family, but they actually decide that they want to receive the same messages or they want to receive different cultural versions. And we're giving them that choice. And that's quite powerful, because if you give people choice over what they receive in terms of their health interventions, they're far more likely to engage with them than when we prescribe it for them or tell them what they should be doing.
In terms of the evaluation, I don't know if it's still ongoing. I mean, you talked a bit about the sort of adoption and engagement. Do you have already any sort of results around kind of the behavioral outcomes that you see from this? Are there any particular areas that you saw some good impact on?
Yeah, so we did see a positive improvement in childhood immunisation rates. So we looked at the rate of achievement of all key immunisations up to 6 months of age, and the sample of the program and the wider population. Unfortunately, a lot of our key outcome measures like immunisations were very heavily affected by COVID. So this study and this program was designed pre-COVID, and I'm sure it's also happened overseas as well, where there's been big drops in things like childhood immunisation and engagement with services because of lots of reasons, but particularly because of the impact of COVID itself and associated lockdowns. So we had some quite big lockdowns here in New Zealand, but also as a result, we've had a really stretched health workforce. And so we've seen sort of it's harder to access services. So even people with good intentions to access, say, primary care services, there's been a lot more barriers to accessing those. So unfortunately, the quality of the evaluation data is not great, but it's still really, really valuable in terms of telling us a bit of a picture of what's going on. I think the important part of the evaluation will also be the bit that's still to come, which is that analysis of the engagement data. So all that system data that we've got around how people engage with these programs, at what point do they enter the program? So when do they sign up for it and when do they drop off the program? So we wouldn't expect people to sign up at 5 weeks pregnant, which is when the messages start, through to their child's 2 years of age. That's 2 years, 8 months of intervention. And that is a huge amount of intervention. If we think about public health programs, it's very rare that people would stay in some kind of intervention like that for that long. We do see that with Text Match. We've had huge numbers of people who have stayed in it that long, but we wouldn't expect that. We expect people to have a natural kind of cycle of when they would stop engaging. And it might be that they only want it during pregnancy, or it may be that there's a certain point, like when the child gets to about 1, where maybe they have more confidence and have better support around them, that they don't need the program as much. So we are interested in looking at that. We're also interested in looking at who is signing up, what their demographics are, and if we're seeing different rates of engagement and with the program between those different groups as well.
I have one concluding question, if I may. Just in terms of something I was wondering about, you were talking about sort of maintenance of the intervention and sort of the continuous updating of sort of relevant issues on the app, and I suppose the languages and so on. And do you have any thoughts about sort of how that can be done going forward to, it's such a beautiful, well thought out intervention. Can there be sort of a system in place to ensure that these kind of suggestions are addressed?
Yeah, I think there's two parts to that. One is that we should never roll out a health intervention like this without factoring in the constant engagement with the people who develop it, or the researchers, or whoever the team behind it is, so that they're constantly there to ensure that we're delivering up-to-date information. So national guidelines might change, new evidence might come out, and we need to make sure that those messages are updated accordingly. What we often see, particularly in the app space, is an app is developed, it's put into the app store, and then it's there and it doesn't get updated. And that's hugely risky when it comes to health, less so with, say, information like this one, but it's really important that we keep these programs up to date. Phone numbers and websites are up to date, etc. So I think we need to ensure that any kind of implementation model for a program like this always includes or factors in the involvement of the team behind the content. In terms of allowing us to add or change content based on the context or the issues for the population at the time, what we need to do, that is actually very easy to do in text messaging programs. It's very easy for me to edit a message and update the content library. And so that's the benefit of a text messaging program, is I literally just update a spreadsheet, an Excel sheet, and update it. It's not like an app where it's a bit more complex in terms of updating content. The issue comes in, we need to, well, I think the issue we've had and why we got that feedback was that we haven't probably communicated well enough with our community that we can do that. So I think they weren't aware that that was an option and how to let us know they wanted to do that. And so what we've got to do is make sure that we're constantly communicating with our key stakeholders, so that if there are key issues or that they want to add to the txtpēpi program, we're aware of those and can go through the process of doing that.
Yeah, I think that's a very good point. If you sort of like have a standardized process in place, with a range of questions, and that you can then sort of feed it back into your spreadsheet, that sounds really good.
Yeah, because one of the issues is that we often don't factor that in. We often just put these programs out there, and we don't think about that side of it. And so it is about just making sure that that's built in, and making sure we facilitate those opportunities for connection with key stakeholders, so that we're always they're always up to date on what's happening with the program, but B, we're up to date with what's happening in the community.
Very good. I also really like the simplicity of the text messaging. I think, yeah, just with my wife recently having had a child, you actually don't want to spend, or you don't even have time to spend time on an app going through something, even if it's well designed. You're just running, sort of taking care of the baby, and actually a message that's much more straightforward, right? So it's intuitively, it makes a lot of sense.
Yeah. The biggest negative feedback we get about these programs is as I said, we integrate feedback into the program. So every about 2 or 3 months of messages, they get a message saying, hey, what do you think of these messages? Please free reply with any feedback type thing. And so we're constantly monitoring that feedback. And the only negative feedback we've pretty much received over the 8 years of delivering Text Match is that the messages are too simple. And when I see that, I'm always kind of okay with that. I always feel good about that, because I know that person has probably got the health literacy and the resources to access the information they need, and that's not who we're targeting with this program. I think the power of these programs is reaching the communities that our existing services aren't reaching. So I'm kind of okay with that, and I think the simplicity, as you say, is really great, particularly during the postnatal period. But it does mean that our reach is greater to those populations that need it the most.
Yeah, fantastic. Thank you very much, Rosie. We're coming up to the hour. Thank you, Elisa, also for joining us. Have a nice rest of the day, or yeah, you are going to bed soon. So thank you very much for your presentation, and thank you for the great discussion.
Thank you very much.
Okay, Rosie. So I'm sure if anybody wants to get in touch, that's easy also to do via email. Yeah. Okay, fantastic. Okay, have a good evening, Rosie. Bye-bye.
Thank you.
Bye, Elisa.